So we have a neurologist, a psychiatrist, and a pharmacist, and about 20 minutes to talk about a mind and body approach, a golden thread through our health system. So Mike, Siobhan and Mark, I've said your formal, those titles, because you do various things, but I wanted to find a little bit more about your current role in King's Health Partners, what your ambitions for it are, what your focus is within those roles. And Siobhan, you're in the middle, so I'll start with you.
So you've already said my current job titles, and I feel I'm a bit unusual in here because I'm a pharmacist, so I snuck in, and I don't want to show off, but I have lived and breathed KHP through literally my entire career. So I started at Guy's and St Thomas's, then I moved to the Maudsley to specialise in mental health, and as everybody at Guy's and Tommy's knows, you can never really leave. So I've been back there to do liaison psychiatry. So I've always had a foot in mental and physical health, and never quite understood why nobody else would feel the same way. And so that's what it's really about for me. So I've spent a lot of my time, sometimes quite literally, cycling between each of the hospital trusts, all on the same day, seeing different patients, and people often asking me, in fact, Mary, who is it exactly that you work for, Siobhan? Because you do seem to be everywhere. But that's what patients are, right? So patients don't exist in one single team or one hospital or one structure, and so neither should we. And when I first started in hospital pharmacy, listening to Rashna's fantastic talk, I remember the chief pharmacist saying to us, now look, you're starting in hospital pharmacy, but just remember that the majority of patients are out there in the community. Which is true, but it also makes it sound like there's a population in the community and there's a population in hospital. But of course that's not the case at all. People move across the boundaries. And so that's for me is the golden thread of mind and body, is actually if we're going to manage population health, but also individual health from a mind and body approach, it means breaking down those structures, because if we're going to do it for patients, we need to do it for ourselves. So it's about recognising that, yes, you may be employed by SLAM or Guy's and Tommy's, but actually we are part of KHP, and we are so lucky to have that.
Siobhan, thank you so much. And Mark, over to you. A little bit about your current role in KHP and yeah, what your ambition or vision for it is.
I mean, we're all three of us starting on a new page of the sort of mind-body programme in KHP, and it's a sort of clinical academic partnership. I'm nominally the academic lead, but I don't see myself really that way. I see us all as part of this clinical academic process, because as well as the things that Siobhan was saying about the need for joining up clinical services, that needs to be joined up with research as well. And research itself is commonly siloed, both in sort of categorical diseases between physical and mental health, and that doesn't really benefit our patients. I mean, my background is a neurologist in movement disorders, and it took me quite a while really to realise that Parkinson's disease, which one thing I was interested in, wasn't really a neurological condition at all. It's a neuropsychiatric condition, one of the commonest at that. And then I moved into seeing many people with functional neurological disorder. So looking at people who really don't fit into any box that we currently have in healthcare, and seeing the massive inequity really of provision of care and services to those patients. And it's that that's really made me feel that we need to do something different in research and clinical practice, and that the mind-body programme offers maybe a big lever to be able to do something positive from that point of view.
Thank you, Mark, and I hope we can maybe pick up a little bit about inequity in a moment. But Mike, before we do that, again, same question, your role and why?
So I work in the brain injury team at King's, which is an integrated multidisciplinary team. I've only been there for 2 years. I trained at King's and then trained at the Maudsley for my mental health training, the IoPPN, and then got tempted away to southwest London to develop an acute brain injury unit at St George's, which was really the beginning of my experience of working in acute trusts rather than mental health trusts. I spent 6 years there. We did some really brilliant things in terms of integrating mental health into traditionally a place where it wasn't thought about in the brain injury service, in the brain injury unit. And what we realised was that actually all of the people that came through that service, actually there was a significant proportion of them, 70% of them, that had mental health problems, often undiagnosed, often with anxiety disorders which had led into having alcohol dependence or harmful use of alcohol as a way of managing that, and then that was the major risk for people having their brain injuries. And this was a rich opportunity to see mental health really up close and personal in a setting where nobody was really asking about it. And that resulted in a project which delivered not only improvements in the patient flow through the service, so we saw people decreasing their length of stay within the major trauma centre and the regional neurosciences centre by 50% of the time, in comparison to the peer group that weren't receiving that integrated care, but also the cost effectiveness of the integration of mental health into the service was really significant, with around about an £800 a week care cost reduction for people that had the integration delivered. So that really made me realise, actually, I can sit in a mental health service and never see people with a whole load of other physical health problems because they don't get access often into mental health services. But similarly, if I'm working in a predominantly physical health focused service, bringing that mental health expertise not only to the people coming to the service, maybe for the first time that they've even been able to see something. Nobody realised I was a psychiatrist, by the way. I think that's the way that I did it. It was a bit of a Trojan horse opportunity to talk to people just about normal things that were affecting their lives. But that also obviously had a massive impact on modelling the behaviours of the people that I was working with in the team. And everybody started to think, actually, mental health isn't somebody else's problem. It's all of our problem.
Thank you, Mike. So already we've got the sort of the sense of what's required in integrated care and mind and body, which is bikes, flexibility, Trojan horses. But can we say a little bit more? Can we stick with this idea of mind and body for a little bit longer? Because we're alluding to certain aspects of it. But can you talk to me about your ideas as to what it is, but also just why it is so important that we have that type of approach across our health and care system? And maybe, Mark, if I start with you.
I think it's a very simple thing, and Siobhan already mentioned it, it's because that's what happens to people who are ill. I mean, we spend all of our time, or 99% of our time, thinking about diseases and people who have diseases, but we don't really think about what it is to be ill. And being ill involves being a human being, fundamentally. And the aspects of that are very complicated. They are bidirectional, so they are with the influence of physical health into mental health. They're around people's educational opportunities, their social adversity, and then the impact of disease on the way that people feel and think. And those things are quite simple. And actually, if you look at any mission statement from any health organisation around the world, it talks about biopsychosocial this, whole person care, personalised that. But it's just, we have to face the fact that that's just rubbish. I mean, we don't provide it. And those of us who work in clinical practice recognise that we don't provide it again and again. And I think that experience often paradoxically leads to a negativity and negative attitudes as well, because when you can't provide what you know you should be providing, it makes you feel uncomfortable, and that makes people put up the barriers. And so when people come with for example, mental illness into a neurological setting, people say, well, that's not my problem. People come with neurological illness into a mental health setting, well, that's not my problem. So there's this kind of inequity and a sort of poor care and a sort of fermentation of poor attitudes amongst healthcare professionals, which is driven by the fact that our systems don't allow us to do the thing that we know is the right thing to do.
Siobhan, do you want to say a bit more on that?
Yeah, I mean, I'm going to bring you guys in as a team because I feel like I'm going to be a bit rude. As a team, we feel very strongly that you may think you're running a world-class, fantastic heart failure clinic, whatever, but you're not if you are not including mental health care in your clinic and in your thinking. And so a mind and body approach is actually essential to providing a proper world-class clinical service. So I'll give you an example. So there's a community project in Lambeth, I believe, run by pharmacists focusing on really high-intensive lipid management. Incredibly successful. They've got amazing results. Brilliant. And when I went to go and speak to them about it, I said, I suppose, what was the difference with people with serious mental illness? Because, we all know bipolar disorder, big increased risk of cardiovascular death, 3 times the amount of depression in populations with cardiovascular disease. So it's really prevalent. They said, it's interesting, because we didn't think to look at that at the beginning, but the pharmacists on the ground were saying, actually, the people not doing so well in this programme are the people with mental health disorder. So now that seems really obvious, perhaps, to us, but that's a real example of where embedding these things from the very beginning, I mean, academically is lovely and fits with everybody's lovely mission statement, but actually that also makes for an economically better clinic. So you are going to get better results from your clinic if that's what we're treating population health, as well as for those individual patients. And that is how we can address population health, city health, global health. It needs to come in from the very beginning.
Siobhan, Mike, do you want to add to Siobhan's points?
Yeah, to add to Siobhan and Mark's points, I think one of the things which I found really interesting recently is you don't get into services if you have mental health problems. You don't get into services if you have physical health problems in both directions. But then there's a whole group of people that we seldom hear from who have an even rougher deal if they have mental health and physical problems and trying to access services. So I think people that are rough sleepers, who are homeless, people who are prisoners, so in our criminal justice system, we're neglecting their health, and they often have exceptionally complex challenges in terms of their needs, and they're not getting into anything at all, and there's no parity of esteem between mental and physical. And then there's a whole group of disenfranchised people. So just to give you an example, people that are subjected to intimate partner violence, so domestic violence, represent around about 80% of people with brain injury in our prisons. That's absolutely ridiculous. And not only are you in prison as a result of your brain injury, but you're there because you got the brain injury from your partner who hit you. And so you're at disadvantage. Obviously, that's often women that are in that situation. So I think that's the kind of example where we need to look at these interfaces, the kind of intersectionality between physical, mental health and social need as well, so that we can actually reach into these services and provide better outcomes, which is what we all want to do.
So Mike, picking up on that a little bit, I was struck by our keynote around, it requires organised efforts of society in order to impact on population health. And it was noted that gains have been made in population health for large sections of the population. But what we're speaking to here is there are significant populations that have not benefited from those population health gains. If we think about smoking rates in people living with serious mental illness, they've had exactly the same exposure to national policies, but it hasn't made an impact. So I wondered if I could ask you to sort of think a little bit about how is a healthcare system with the powers that are available to us within kind of integrated roles, within perhaps in King's Health Partners, what can we do differently, or what should be done differently, either in the commissioning of services, in the delivery of services, or in the behaviour of individual practitioners to try and impact and change the sorts of things that you're describing, Mike, these structural inequalities and these persistent inequity for people living with mental health problems?
So it was such an interesting morning, and also I've had to stop myself getting irritated at times by the fact that some of the things that we commonly talk about, for example, digital technologies, being able to allow people to access, for example, apps to improve their mental health. These are fantastically important things, and I would fully support them, and I think their access should be better, and all of the things we talked about today, but they miss the people who have the highest levels of need, who we are missing at the moment and will continue to be missed if all we do is focus on the sort of so-called low-hanging fruit. That's stuff that we need to do. But we also we can use that data to identify within our system, if the data processes are working properly, the people who our system is failing, because they are the people with multiple contacts across multiple services, across physical and mental health and social services. And we could identify those people and we could intervene. We could work out why it is that we're failing them, and we could try and do the right thing. And the right thing is not likely, unfortunately, to be a digital technology for those people. It's likely to involve human beings. It's likely to involve services which are relatively complex and probably relatively costly. But the things that we would save from that in terms of human suffering and quality of life and money would be enormous. So I'm always feel we need to keep a balance when we're talking about things that we can do at a population level, which we absolutely have to do and make a massive difference, and not forget the things that we need to do at a more individual level for people with high levels of complexity. That's particularly the case for people with serious mental illness.
Thank you, Mark. I think really helpful comments. Siobhan, I wondered if you wanted to add any more as to what needs to be done differently in order to try and redress some of the significant inequity.
Yeah, I totally agree with you with being a bit annoyed and thinking, apps just are not going to be the answer for a lot of these people. And we've talked a lot about child and adolescent mental health, which is undoubtedly vitally important. But let's not forget about the adults with, treatment-resistant schizophrenia, who, the approach just does have to be different. But we've got the people to do it here. I think that's what it is for me. We've got some of the most excellent staff at KHP, and that there is nobody who doesn't want to do this. So it's about making friends. I'm sorry if it sounds twee, but it's about holding hands across the zebra crossing at Denmark Hill. The cardiology pharmacist at King's doesn't know who the addictions pharmacist is at the Maudsley, but they're less than 50 metres away from each other. And this is something that the Mind and Body programme, we've been working on it for the past 3-5 years now, part of the IMPS programme. It is sometimes as simple as linking those people up. Because it's all very well me being on my bike and going between the hospitals and everybody knows who I am, but that's not very sustainable. But actually, teaching programmes, cross-cultural divides seems so simple and so straightforward. And to me, it's not really about the knowledge. It's about then knowing who those people are and being able to pick up the phone or drop an email because you know that person and you've met them, which speaks a little bit to what Mark was saying about, yes, it's big population approaches. It's also individualising approaches, and sometimes it does come down to those sorts of relationships. And that's how I think we need to have the vision of how we work as KHP.
Thank you, Siobhan. And Mike, anything you want to add to that discussion?
So I think trying to think about the simple things that we can change in terms of how we think about, how we feel, what we do about mental health in all conditions is really important. We constantly talk about the biopsychosocial approach. There's a big debate within psychiatry at the moment. We seem to have lost the psychosocial even in psychiatry. We focus on the biological, we focus on diagnosis. We've taken biopsychosocial formulation out of our trainees' training and in their examinations. There's a whole generation of psychiatrists who aren't thinking in a way which cuts across biopsychosocial domains. But I put the challenge out there that I don't think any of us as healthcare professionals are effectively thinking about biopsychosocial in all of our patients. And actually, if you bring the psychosocial back into your thinking and into your perception and you're aware of it, you'll start to see your patients in a different light and you'll be able to do things for them which otherwise you wouldn't be able to do. So that would be the one thing, that kind of call to action that you could change in your teams, in your practice today, is to start to, rather than just focusing on diagnosis and tests, to pull that together into a narrative and into a formulation which makes sense for that person on the ground. And that's going to change the way you treat them and how they do in terms of their outcomes.
So can I pick up on that point? We had a comment from Ilias who'd said the World Health Organization rightly defines health as a state of complete physical, mental and social well-being, so we must not overlook the social aspects. So this feels a really important part of the conversation, but earlier today we'd also heard about the necessity of data, that how we can then use that to inform some of the stratification that you're talking to. But some of the issues we have is that information about social situations for the people that we see is not in our data sets. And then we could say, well, maybe we should start screening for social determinants, which I know has been a big move in the States, but then we also talked earlier about we don't need another form and who's going to fill in that form and so on. So I wondered if you had seen good examples or had ideas for the Mind and Body programme as to what it would actually look like to start to get more serious about the social determinants and about the social factors that impact on people's ability to look after their health or engage in preventative activities. So any good stuff you've seen or anything that you think as a programme that could be done?
So I'm thinking maybe a step above that, which is our integrated care systems are evolving and maturing now, and we're devolving commissioning from specialised commissioning into the integrated care systems, but there isn't very much talk about integrating physical, mental and social need within our integrated care systems. And clearly that was part of the vision, but it's not really out there in the language of commissioners, certainly the people that I've worked with within neurosciences. It's not there. And so I think in order for us to achieve that integration of social care as well, we need to start having those conversations at the system and commissioning level. Actually, integration is absolutely critical to this. One of the things that we're seeing with the serious mental illness review that's happening in South London at the moment, South East London, looking at essentially the prevalence of physical health problems in people with serious mental illness, I hope is going to give some real granularity to those conversations about the importance of helping people who have mental health problems manage their physical health better, because we don't even have that data in terms of understanding that. That work's nearly coming to fruition, and I think it will point towards things that we can very straightforwardly do. So listening about how you can provide people with blood pressure management, you'd hope that you'd be able to deliver something similar in the O2 around mental health, mental well-being. And I think we hear a lot in the media about mental well-being. We talk about mental health problems, mental illness, I think is a word we don't like using, but it's a real thing. But clearly well-being is going to be critical in terms of prevention and making sure that all people are being screened in terms of their mental health, looking for opportunities to actually improve and decrease the risk of them developing mental health problems. That's a conversation you can have anywhere.
Yeah. Thank you, Mike. I'm just going to go to a couple of questions that have come through online. I wonder if picking up, it's picking up on Rashna and Mandy's presentation, but the Vital Five is about identification, early intervention or prevention. And there's a question that came through as to, what are the barriers to spreading and scaling some of these Vital Five interventions to wider populations? So that question seems to resonate with our issue, our frustration that some people living with mental health problems, access to the tech, access to the shopping centre, especially for people with some functional neurological conditions, is not a given. So I wondered if we could think together about what are some of the barriers for a range of mental health conditions in being able to sort of achieve the benefits of that type of Vital Five prevention programme, and what could be done differently?
So I think that we, in a sense, this is a sort of iterative process, and it is reasonable to start somewhere. And we've heard fantastic examples of that, about how you can increase uptake of sort of straightforward screening techniques, which saves people's lives, saves years of illness. But through that process, through starting doing that, you start to identify the people who can't engage with that process, who are not being reached by that process, let's put it that way. And that allows you to understand why. So that, to me, is the sort of the big data question is that you use the technology to, and whatever else you can to introduce these techniques, but then you identify those people who are not benefiting, and then you can answer the question why. And I think that would then lead to more and more targeted interventions for those populations.
And taking us to the personalised.
Exactly.
Yeah. Siobhan, did you want to add on that?
Yeah, I was just going to build on that. I think that's right, is that this is going to be difficult because lots of the people, if I can put it that way, that we're talking about, as you say, are not going to be in the Glades shopping centre, or if there are, they're not going to come and engage. And so I think Mandy's example of where you went out and got into the population you were interested in, so you went to them, that is what we're going to have to do. And that is harder. But it is vital in the Vital Five. We're just going to have to do it that way because it's that those hidden voices and that hidden population that we just mustn't miss. And it also then links into, as Mike was saying, about what we're doing with the SMI review, because we discussed earlier on today that our services are sort of spread all over South East London without much thinking about, but where are the actual problems and are we focusing in the right places? And so by linking up the data, then hopefully we can find out, well, actually this particular pocket here, that is a place where hypertension is a really big issue. So actually we're going to go there and focus on that population there. And perhaps over here it's diabetes management. But as we were saying, without those data, it's too big a problem. And we don't have endless amounts of money to focus everywhere. So I think that's the power of data and making it personalised to our own population here.
And the challenge with that is, I mean, Mike, you'd already led to it, that this done well leads to significant economic, not just ethical benefit. So we only have one more minute together, if that. So this is your time really for your ask. So Rashna laid us that challenge. She said that in order to do this, people have got to do things differently. So if you had one wish or one ask of the people in this room or the people watching, what would you like them to do differently in order to support a mind and body approach as spread through our health system?
Maybe one nice thing about the English language, it has lots of different words for the same thing. But I've always liked the fact that we can hear, and we can also listen, and we can see, we can also look. So there's this difference between superficiality and perception. And so my ask would be that people really try and listen and look, because as soon as you do that, you identify these sorts of problems that we've been talking about, which the patients are not going to tell you because they don't think you're that kind of doctor or health professional that they're going to talk to about that. And you maybe have missed, but it's that we need to start doing to identify this significant cause of disability, of treatable disability in our patients.
Thank you, Mark. And Siobhan?
Go out there and make friends. Because actually, this is quite scary, right? Because us saying you must focus on the mind and the body, and that's quite intimidating, but I don't know how to treat heart failure. You don't have to, because there are people out there in KHP who know that bit. So you need to go and find them and bring them in to help that patient in front of you. So go out there and make friends with people.
Thank you, Siobhan. And final word for you, Mike.
So I'm going to say, make friends with us. So we're new, we're the new kids on the block. We'd like to come and meet everybody across the CAGs in KHP and actually have those useful conversations about how do you do this? Because it's not easy, otherwise everyone would have just done it. And then the last thing I'll say is, every time you think about something physical, always say, where's the psychosocial? You've got to always ask it. There have been fabulous presentations here today, but I was sitting there going, well, where's the psychosocial stuff? There was clearly going to be some of that in it, but it wasn't presented.
Thank you. So thank you all. I think summarising your ask to the system, listen, make friends, come talk. And I think that's an invitation also to people very much watching online. I think the excitement around King's Health Partners at the three of you taking up these roles of co-clinical director and academic director of the Mind and Body Programme is palpable. I personally am extremely excited. I also wanted to thank Professor Carr, thank Rashna and thank Mandy for some brilliant presentations. And again, it's sort of a wider call to us to say that we do need to do things differently. That is the challenge. And I hope over the remainder of this conference, that's the remaining theme of out of this, what do we need to do differently in order to make things look differently for the people in our communities? So a huge thank you to you all.